All right. It's on my face.
Hello, Norm.
Welcome back, Claire.
Hi, guys. We super appreciate everyone watching.
Yeah.
If you're out there,
all the comments so helpful.
It's very helpful. No, okay. So last week we talked a little bit about what did we talk about? Pain.
Context of pain.
The context of pain and how that contributes to your pain experience and what you're feeling and how that's different for everyone, mm-hmm. right? The concept that I wanted to talk about is kind of a two-part, but play in together, is this idea that your pain experience is enhanced or made worse or made more problematic by two things. One is your fear about what your pain means, and then two, your lack of understanding about what your pain is. So those two things can be separate entities, but they often kind of go together because I'm going to be afraid of what I'm feeling if I don't understand what I'm feeling, kind of thing.
And pain and understanding being both cognitive exercises that, like, it's in your head.
Yes. And you know, and we can truly talk about, like, what specific a true understanding of what my specific back pain means, or what's, you know, what SI joint dysfunction means, or what sciatica means, you know, just as a, but even in a bigger sense, that pain becomes less threatening. So when we look at, like, the research behind pain neuroscience education, and the reason why we're doing videos like this and talking about pain, is that the number one thing that makes a pain experience better for an individual or less threatening, or my pain decreases, is with understanding of it. So everything we've been talking about, you know, in the understanding the neuroscience of pain, how your brain orchestrates this production of what you're feeling, how your nervous system takes in input and creates that message for you, and truly breaking that down and understanding all of these different concepts. It's like pain values. So just visual analog scale, rate your pain from 0 to 10, or, you know, less, your quality of life improves, your hope about your pain experience wildly improves. So your sleep improves, your stress lessens. So, you know, that in a more global scale is even compared to other modalities like manual therapy, exercise, all of the things that we do in the physical therapy realm, pain neuroscience education is still the top, you know, in terms of helping. Yeah.
So, like, when you say in terms of top of like what's helping, that's compared to what alternatives? Surgery? Pharmacological interventions?
So, well, I was even saying just in the, like, in the PT world of, like, if you had someone, one group, all presenting the same, one got pain neuroscience education, one got E-stim and heat, one got therapeutic exercise, one just got, you know, manual therapy but without education, or, you know, that is
pain education is at the top,
the front runner.
Wow.
You know, I always would say too, and I think that that's what would make me stand out as a clinician, or make people talk about, you know, oh, you need to go see Claire. I mean, I could, even if I'm just gently holding someone, cradling someone's head, you know, or just doing some very minimal manual therapy, you know, skills that maybe, I mean, yeah, we could argue that energetically there's a lot happening when I've just got my therapeutic hands on someone, but nothing super intentional or specific to treat a specific diagnosis. And just talking to them and educating them, they get up and they feel better.
Now, is this across the board? We're talking about post-op, and then, you know, like high school athlete who's tweaked something, like coming in with pain education across the board. Is it going to lower?
Yeah. So I think, you know, with research in general, I think there's a lot of, like, inclusion and exclusion. I think in general, what they are finding, and there's still constant pain neuroscience education research being done, that is across the board better. The more you understand something, specifically about pain, the less threatening it is, which so I've been doing a lot of videos just like describing a diagnosis, right? So if you go and you get a diagnosis of bursitis, I'll have clients come in and, you know, okay, so tell me what's going on with you. And, well, my hip bursitis is acting up. But, I mean, don't worry about that. Well, why don't we want to work? Do you know what that means? Do you know what that, it was almost like a write-off of like, well, it's just my bursitis, like that'll go away. That's not going to go away unless you understand what it is and how you can get it to go away, right? So this, I think across the board, a better understanding. One example that I use a lot in my presentations on understanding pain is this example that was, I think it was by Lorimer Moseley, who's this, you know, great pain researcher. And he talked about there was a group of elderly or older adult individuals that all had hip osteoarthritis. So, you know, when you do a research, you know, project, there's a lot of inclusion and exclusion criteria. So all of these people could be male, female, different race, but they are meeting the similar criteria in terms of how their images looked, their age range, how much pain they're describing they're having, the quality of life measures, all of that stuff. So you've got a group of individuals who are different, but when we objectify them on a few planes, they're the same, right? And they all qualify for a hip replacement. So they are going for a hip replacement by the same surgeon and the same kind of pre-op, post-op crew, same rehab specialist, all of that stuff. And they took these individuals and divided them into two groups. And one group would sit one-on-one with the surgeon and would talk about the procedure. So he would often give them like a prosthesis to hold and like, oh, do you feel how good that feels? And, you know, for someone who's bone on bone to feel that smooth, you know, titanium or whatever, you know, they're using is, oh my God, you know, and they say, oh, you're going to feel so much better, very positive. Here's what's going to happen. We're going to take that old gunky hip. We're going to get it out. We're going to put this new prosthesis in, you know, it's going to snap right back into place. You're going to be able to stand up immediately. So this, the language used, very positive, right? Very, very good. So they're getting an education. Arguably, it's not a full description of what's happening in the procedure, but it's a very positive, you know, positive presentation of what you're going to get. The other group was put in a room together without the physician, and they watched a video of a hip replacement.
Which is wild.
Which
like,
is barbaric.
Saws, hammers, like
it's threatening. So you watch something like that,
like Saw,
without someone being like, look, this looks crazy.
Yeah.
This looks like a saw. And it is but no one's there, you know. So these people watched a video of a total hip replacement. All of these people had their hip replacement, same physician, same surgeon, same procedure in terms of anterior, posterior, same prosthesis, and they rated their post-operative pain complaints. And that group that saw the video, but without any of that positive feedback, rated their pain as much higher. Considerably. I mean, you know, when you talk about research, it's a statistical difference in pain ratings post-operatively. And that also speaks to like language matters, your words matter, right? Like how we talk to patients. I use the example of like, please, if any physician is watching, stop saying you have the back of an 80-year-old to your patient with back pain that you get an image of.
Yeah.
It's not helpful. So like our language that we use, if we're trying to connect with a patient and make them feel validated and seen and heard, but we're doing that with language like, oh, it's the worst back I've ever seen, you're missing, you're not actually doing what you think you're doing. You're actually making the fear component much worse.
It's almost like you're validating their worst fears. So
That's exactly
you're,
right.
You're trying to validate, which is good.
Right.
Right. But the thing that you're validating is actually raising the threat value, which is increasing the pain experience.
Sure.
So if you want to lower the pain experience,
right.
validate a different way.
Yeah. And like another way we talk about like the fear around your pain experience is how many of us have put our symptoms in WebMD?
Yeah.
And come out with a list of this is what it might be, right?
Cancer.
And cancer is always on that list, right?
It doesn't matter what the list is.
It does not matter what the list is. And there is no one that has any healthy understanding of cancer in terms of it not invoking any fear.
Yeah, that's right. Yeah.
Right? I mean, we may have had people in our lives who have survived cancer, right? But no one wants cancer.
No,
and even the ones that have survived cancer, it was a nightmare experience. It was a horrific experience. And so to pop out a list of this is what it might be and cancer's on there, you're automatically like, this is what it is.
Mm-hmm.
This is, and it's hard not to do that as a human, as a, and even if you can coach yourself, it's not cancer. But then there's that little thing, might be cancer.
Might be cancer.
Right? And so how that perpetuates your pain experience. You can get up off the computer and feel much worse than when you sat down,
100%. And the only thing that changed was right here.
Yes.
Okay. So,
arguably if you sat at the computer with funky pot. Anyway, no, but you're right.
So to highlight, I think a theme that we've been talking about, this is paradigm shifting in a little ways from not just today's video, but also the other videos before, in that when we talk about the resolution of somebody's pain experience, formerly, and perhaps still predominantly, in most people's minds, what that meant was tissue damage is being healed.
Right.
That there is a physical restoration of a biological process that is taking place.
Yes.
Whereas today, and what you're talking about right now, is that the resolution of someone's pain experience may or may not include a physical restoration of a biological process.
Right.
But often can and does include a cognitive or emotional shift in either increasing understanding, decreasing threat value, validation of emotions.
Yes.
None of which may have anything to do with what's going on in the body, but nonetheless lowers the experience of pain that one has.
Yes.
This seems revolutionary. It seems like good news.
No, it is. And I think it's like what I teach a pain elective at the PT school here, Fran U. And what I try to tell them is that this is the language and this is how you can approach every single individual who comes to you, if they are a pain patient, which most people, in the PT world, that's at least some component. And it's almost like whether or not there is actual true tissue damage, or if that tissue damage is very small in comparison, every single one of those people who is standing in front of you talking to you about a pain experience has the mental, emotional, social, all these other factors that are at play in participating in some nervous system driven pain experience, right? Mm-hmm. And what I mean by that is that tissue damage and tissue inflammation and things like that may often be present, but whether or not it's present, the other bigger components are always present and can always be addressed, right?
And
with your language, and need to be addressed. Yeah. This is why when in the clinic, even if who I was seeing was a simple post-op or an injury, I'm saying simple, I mean, just a very clear-cut presentation, an injury, a specific diagnosis, a post-op, I'm still having these conversations with these people about all of the factors that contribute to their pain, their healing potential, all of those things. That way, in that moment, what they're healing is a very holistic, but in the future, when they have something flare up, they have a way better understanding.
So it's almost like, I mean, you're resourcing the client or patient for like long-term wellness.
Yeah.
Like, yeah, which seems like you're building some innate resiliency against future pain. Is that?
To me, it is that is the way we make a difference in the pain epidemic, right? And we've alluded to this. It's almost like the government, attorneys, people are playing into the opioid crisis.
Yeah.
And that is being addressed. And the physicians have a better understanding, like people prescribing medicine have a better understanding of, opioids are rarely helpful, right? Yeah. And especially when you look at, like, there's even been studies done for like a true patient with central sensitization, which is the patients who maybe less tissue damage and more nervous system generated pain experience. The opioids, in comparison to all of these other, anti-inflammatory, muscle relaxers, all these different types of pain, like neurogenic pain medicine, stuff like that. The number one medication that is helpful in decreasing a pain experience is SSRIs. They're like anti-anxiety and antidepressant drugs. They're serotonin, like they're boosting your nervous system component of how you're handling stress, right? That's a pretty wild.
Okay, so I know, like, and we're gonna have to land the plane. Maybe we do this next time. So,
I got off on a tangent. I apologize.
I know people, you may be watching, but I know people who would say that, like, if I didn't have, like, Percocet or Oxycontin, like, oxycodone, whatever, like, there would be days I just couldn't make it.
Yeah.
Right. And over and against, physical therapy or pain education, there seems to be this is what I want to ask. Is there a role that pain medication, pain management plays in treating the pain experience? Or do we want to say, look, it's effective at what it does, but the cost of...
Right. The cost of... Well,
it's like alcoholism.
Yeah.
Like, alcohol is please hear me, that I'm not equating that if you use pharmacological interventions of pain, it's the same as alcoholism. Then what I mean is that alcohol is an incredibly psychoactive chemical that works really well to alter your experience.
Right.
Now, eventually, it stops working so well.
That's right.
And the cost of it working well is less than the cost of what it's costing you to use it.
That's right. And it's the example that people get with alcohol where it's like, oh, it relaxes me. When in reality, we know that maybe in that first little bit and what it does to your dopamine and all that, but right after that, it becomes a stimulant. It becomes, and so it's like, it is similar in that where, so I would say there is a role in, when talking opioids, in a post-operative.
Right, okay.
There is still, but I think also even other alternatives exist in that realm. I think we can't discount or we don't know how much of a person's benefit from a specific medicine is not also some placebo, is not also some nervous system generated, this is going to help me, and it does, and now I've made sure, and that's, again, not to say it's all in your head and your Percocet's not really helping. It's more of for those people that they have now tagged that they only feel better when they take that, right? And that's a we can't say that that's true medicine or true, and that's the interesting thing about the placebo effect, is it is equally as powerful as anything else. And it's always in research is the control.
Yeah, right.
And never compared it to a control, right? Like, it's never compared to no medicine versus placebo, or I think they are starting to do that. But that power of you just thinking that something's going to work.
Yeah.
is we can't.
Well, it's like hope.
That's exactly
like,
right.
Like the outcome to measure somebody's success in therapy, in the therapeutic realm, is like, how much hope do you have in the process to actually deliver the change that you're seeking? If you don't have a lot of hope, bro, you're gonna drop out. You're gonna stick it out. But if you have enough hope that we can build and work on, then we actually see that hope increases.
Yeah.
And then this confidence in your outcome increases. And
right.
You go through the tough stuff.
Yeah. I think what you're describing, that hope and that placebo, the belief that something will help me.
That's right.
Just the buy-in is the antithesis of the fear and the lack of understanding. And I think that, to me, should also make you hopeful about your pain experience, right? And what you can do to change it, to minimize it, to not become identified as it and become separate from it and understand more of what it is. And I think, as a provider, that's what I give more than anything to patients, is that hope.
Yeah.
Just the language that I use, or the way that I'm able to and that alone is different. I think. So
guys, it's been fun.
It's a lot of fun.
So we'll skip next week.
What?
Because I am going on a field trip to Volunteers for Youth Justice in Caddo Parish.
Oh, nice. Okay.
So check them out, Volunteers for Youth Justice. It's what we're trying to replicate here at the Grace Mid-City Community Center. A piece of it, anyway. So we'll catch in 2 weeks.
2 weeks. Which is also
Among the Lamps.
Which is also Mardi Gras week.
Which is also Mardi Gras. That's March 3rd.
I'm still available.
Oh, yeah, I'll be here.
Yeah. All right.
Yeah. I'm Baptist. We don't do Mardi Gras. So.
All right.